Hello everyone and welcome to our module on nerve damage. Let's talk about what happens when there is peripheral nerve damage. This is the type of nerve damage that can occur secondary to trauma. It commonly affects the nerves in the arms and the legs. There is an old classification scheme that is still used to describe peripheral nerve lesions. By this scheme, a mild nerve lesion is called neuropraxia, a moderate lesion is called axonotmesis, and severe peripheral nerve damage is called neurotmesis. And any of these types of peripheral nerve damage can potentially result in weakness or sensory loss, and I'll go through each of them one at a time in the next few slides. In order to understand the different degrees of peripheral nerve damage, we'll use this drawing I've made on the screen here. I've got a nerve running down the middle surrounded by myelin sheaths, and then I've got the layers surrounding the nerve on the outside, the endoneurium in green, the perineurium in red, and the epineurium in black. Neuropraxia is a very mild peripheral nerve injury. This results only in focal demyelination. I've shown this in this drawing on the bottom of the screen. A portion of the myelin sheath has been damaged. Importantly, the axon distal to the injury is intact and there is good continuity across the injury, and this type of peripheral nerve damage has an excellent prognosis with very good recovery. At the other end of the spectrum is neurotmesis. These are severe nerve lesions where the axon and the myelin sheath are irreversibly damaged. In addition, there can be damage to the epineurium, perineurium, and endoneurium, resulting in disruption of the external continuity of the injured nerve. In this type of peripheral nerve lesion, no significant regeneration occurs and there is a very bad prognosis. In the middle of those two extremes is axonotmesis. In this type of peripheral nerve damage, demyelination occurs plus damage to the axon. I've shown that in this picture at the bottom of the screen. We've got damage to some of the myelin, just like we saw in neuropraxia, but in addition there is damage to the nerve running down the center. Importantly, however, the external structures like the endoneurium and the perineurium will remain intact in axonotmesis. To understand the changes that occur in a nerve after axonotmesis, let's imagine that the nerve cell body is at this end, and let's imagine that this is the distal end of the nerve. If we have a lesion right here, there are characteristic changes that occur distal to the lesion and proximal to the lesion, and we'll go through both of these in the next two slides. These are classic changes that occur to peripheral nerves in response to injury. Distal to the lesion, the process that occurs is called Wallerian degeneration. This process also occurs to a smaller extent just proximal to the site of injury. In Wallerian degeneration, the axon degenerates and the myelin sheath involutes over time distal to the site of a nerve injury. This is not always permanent. Sometimes the axon can regrow, and this all depends on the Schwann cells. If the Schwann cells maintain their integrity, then axon regrowth is sometimes seen. Proximal to the lesion, a different process occurs. This is called axonal reaction. It's also called central chromatolysis. What's happening in this process is that the cell body is up-regulating protein synthesis in order to try and repair itself. As a result, there are characteristic changes in the neuron cell body that occur. First of all, the neuron cell body swells. It also goes through what's known as chromatolysis. This is disappearance of structures called Nissl bodies. I'll show you a picture of this in a minute. And then finally, the nucleus moves to the periphery, and these characteristic changes occur proximal to the lesion in axonotmesis, and they resolve over time. Here's a drawing from the web to illustrate the process of chromatolysis. On the left is a normal neuron. Note that the nucleus is in the center. It is surrounded by Nissl bodies. In the center of the picture is a neuron undergoing chromatolysis. Note that the nucleus has moved to the periphery, and the Nissl bodies are missing from the center of the neuron cell body. And then over time, the neuron goes back to normal and looks like the image on the right side of the screen. And here's a very nice picture of a neuron going through chromatolysis. Note that it's large and swollen. Note that the nucleus has moved to the periphery. And note that the Nissl bodies are missing from the center of the neuron cell body. Axonotmesis has a variable prognosis in terms of recovery of nerve function. The prognosis depends on a number of factors, including the extent of the damage, the distance to the target from the nerve lesion, and the complexity of the nerve itself. Usually there is partial but not complete recovery, and in general recovery takes much longer in axonotmesis than in neuropraxia. Now let's talk about what happens when there is nerve damage involving the central nervous system, and specifically let's focus on what happens when there is ischemia of the central nervous system. First of all, you should know that it takes only about 4 to 5 minutes of ischemia to cause irreversible damage to the central nervous system. In general, neurons are the most sensitive cells, more sensitive than glial cells. This is because they have higher energy demands, and in addition they lack glycogen to use as a fuel source. Some neurons are more sensitive than others. The most sensitive neurons I've listed on the slide here. The hippocampus is highly sensitive to ischemia, so are the Purkinje cells in the cerebellum. The neocortex, which is the majority of your cortex, is very sensitive to ischemia. And finally, the striatum, which is part of the basal ganglia, is also very sensitive to ischemia. Central nervous system tissue goes through a progression of changes following ischemia. Let's begin by talking about what happens 12 to 24 hours after an ischemic event. There are no changes seen microscopically for about the first 12 hours. After that, the first changes that occur do so in the neurons. The neurons develop small holes in their cytoplasm called microvacuoles. In addition, the neurons take on a deep pink-red color and they become what's known as red neurons. And I've bolded the word red neurons because you should be aware that the presence of red neurons in the brain is evidence of ischemia. And then finally, the nucleus goes through a series of changes in shape and color. Here's a picture from the web. All these dark pink spots are red neurons. This is evidence of ischemia in the brain. After about 24 hours, neutrophils, macrophages, and microglia become activated, and this leads to liquefactive necrosis from lysosomal enzymes occurring in the area of infarction. And then finally, over days to weeks, macrophages eliminate debris and a cyst will form in the brain. Astrocytes undergo a process called gliosis where they multiply and enlarge, and the astrocyte processes will form a wall around the cyst. So many weeks or months or years after a patient has had an ischemic event in the brain, you will see a cyst that has been walled off by astrocytes. It's also very high yield for your boards to know the difference between upper motor neuron and lower motor neuron problems, so let's talk about that now. The somatic system in your body, the motor system that carries out voluntary muscle actions like walking or raising your arm, is a two-neuron chain. The first neuron is called the upper motor neuron, and it goes from the brain all the way down to the spinal cord. In the spinal cord, those upper motor neurons synapse, and then a lower motor neuron goes out and innervates the muscle or the target to create the action that you want. So upper motor neuron problems happen when you have damage to places like the cerebral cortex or the internal capsule, which carries all the motor fibers through the subcortex area, and the corticospinal tract. Lower motor neuron problems happen when you have damage to the neurons that directly innervate muscles, like some of the cranial nerves in the brainstem, or the neurons in the anterior horn of the spinal cord. So you can tell the difference between upper motor neuron and lower motor neuron problems based on the symptoms that the patient has. So patients who have upper motor neuron damage have what we call pyramidal signs, and the pyramids are the portion of the brainstem that carry the motor neurons, so that's why these are called pyramidal signs. So they will have something that's called spastic paralysis. They can't move their muscles, but their muscles are stiff and rigid, and this is very different from lower motor neuron problems, which we'll talk about in a minute. They have what's called hyperreflexia, so their reflexes are hyperactive. And remember, reflexes are described as 0, 1 plus, 2 plus, 3 plus. 2 plus is normal. In upper motor neuron problems, patients will have 3 plus reflexes, and that's the way it'll be described in board questions. The muscles are overactive, and they can have something called clasp knife spasticity. This is where if you try to do passive movement of a joint, you will get initial resistance and then sudden release. That's clasp knife spasticity, and that's a sign of upper motor neuron damage. Contrast that to lower motor neuron damage. Here you've directly lost the innervation of the muscle, so you get flaccid paralysis. The muscles are floppy and weak. You will see fasciculations. These are spontaneous contractions or twitches of the muscle, and you will see loss of reflexes. So instead of reflexes being described as 2 plus, which is normal, they'll be either 0 or 1 plus in lower motor neuron problems. The upper motor neurons on one side of the brain cross to innervate the other side of the body, and that crossing is called the decussation. And that crossing occurs just below the medulla. It's right here on this drawing I've shown over here. So let's suppose for a second you have a lesion up here in the cortex. What will happen is that you will lose the innervation to muscles down on the opposite side of the body, and that's because of that decussation. So lesions anywhere above the decussation give symptoms on the other side of the body. On the other hand, if you had a lesion, say down here after the decussation, it would cause weakness in the muscles on the same side of the body. We call that the ipsilateral side of the body. So very important to know that the decussation is where the fibers cross, and that lesions above the decussation give motor weakness on the opposite side of the body. Lesions below the decussation give motor weakness on the same side of the body. In the arms and the legs and all the areas of the body below the neck, we talk about weakness and upper and lower motor neuron symptoms. But in the muscles of the face and the head and neck, we talk about bulbar symptoms. So what do we mean when we say that? The bulbar muscles are the muscles that are supplied by the cranial nerves in the brainstem. So they are things like the jaw, the face, swallowing, the palate, the head, and the tongue. And I've written here all the cranial nerves that supply all of them. So when these muscles get weak, we call it a bulbar palsy, or we sometimes call it bulbar symptoms. And we mean that the patient has problems in the head and neck, problems like swallowing and moving the head and talking. So a bulbar palsy is a lower motor nerve palsy of the bulbar muscles. So this is cranial nerve damage, and you will have lower motor neuron signs. A pseudobulbar palsy is an upper motor neuron problem. It's problems with the corticobulbar tract, and these patients will have upper motor neuron signs in the head and the neck, in the muscles innervated by the cranial nerves. So some key differences to tell these apart. So patients who have a bulbar palsy will have an absent jaw and gag reflex. Those reflexes are controlled by the cranial nerves, and they will be weak or absent when you have a lower motor neuron lesion of the bulbar muscles. You also see that the tongue will be flaccid or wasted. Patients who have a pseudobulbar palsy will have an exaggerated gag reflex. They can have a spastic tongue that's contracted and it's not wasted, and they get something called spastic dysarthria, and you should go to YouTube and watch a patient who has this. It's speech that is very slow and labored and has a harsh quality to it, and that's what patients get when they have pseudobulbar palsies or damage of the upper motor neurons supplying the cranial nerves in the brainstem that supply the muscles of the head and neck. And that concludes our module on nerve damage.